Hi, everybody. Thank you for joining. Definitely a new platform for this one, given some spacing difficulties. I'm going to give people just a few minutes to join, and then we will go ahead and get started.
Bobby, it has been too long.
I'm still here. Good to see you. I see a lot of faces I haven't seen in a while. Hey, boss. That'd be for, I got a couple bosses here, but my original boss, that'd be Melissa.
Hey, Bobby Ross, good to
That's the
see you.
OG boss right there. Hey, good to see you. Wouldn't be here if it were not for you, so thank you for sure.
You always say that. You're too kind.
All right, we're going to go ahead and get started. I am going to bring on our first guest presenter for the day, Jason Klein, who works with DSP as a clinical contracting manager, to discuss some updates to our back process and the way things are going to be issued both for new studies and for revisions that need to be submitted. So with that, please give him his attention and thank you very much, Jason.
Hey Claire, how are you? How's everybody doing this morning? Thanks for taking the time to let me come in and talk through this workflow change. So I'm going to share my screen. I have a little presentation that we'll walk through here and then have a couple minutes afterwards. Happy to field any questions, but also, even though my role has changed over the past couple of years, I'm still a familiar face to a lot of people. So I would urge anybody that has either history with us doing the contracting work or that wants to establish a new relationship under our new organization to reach out directly. If any of this information that's presented either strikes you as odd or like, how are we actually going to pull this off? I'm more than happy to meet one-on-one because I know different departments specialize in different areas, federally funded, non-federally funded, grant funded, industry-based funded. And so if there's nuances that we need to address based on the flavor of your work product, I'm happy to do that on one-on-one basis because this will be a more zoomed out view and a global approach to this, knowing that there's always nuances to whenever there's a workflow process change. So I'm gonna share my screen here. This is where I wish I was, and this is where we are. So if you guys see where we are, I can pick up from here. So um, thanks for the introduction, Claire. My name is Jason Fine. I am on the contracting team here in DSP with a specific assignment to manage the clinical research portfolio that includes clinical trial work, observational work, retrospective data-centric work, including the university's entire data use agreement portfolio. So we're specifically here today to talk about the change in process when you need modifications or maintenance on a contract that's already activated that requires OnCore management, meaning that you have an OCR number and you're leveraging either the invoicing or the AR activities in OnCore or using OnCore to produce your backup documentation for invoices that need to be paid on any sponsored programs account. So to give a little bit of a background, the history of the OCR contracting team actually started before OCR, when OCR was branded as RAC, the Research Administration and Compliance Team, which was then augmented into the Office of Clinical Research, and now has been further augmented into the Clinical Research Hub under the College of Medicine's oversight. So the history of the level of service that the OCR contracting or the RAC contracting team did was management of all UFirst activities related to agreements. So our team was responsible for entry, data integrity, routing, finalization, and kicking off the next piece of the workflow project process, which would be like award activation and including award maintenance. So when the OCR group was remodeled into the Clinical Research Hub under the College of Medicine oversight, the contracting piece of that puzzle or that activation workflow was removed and no longer embedded within what we now call protocol activation. And so when those activation workflows change and those people are no longer embedded within those same group, it kind of obviates the need to also take a look at and address the specific contracting workflows. So that's the background about why some of these decisions have been made and why we continue to think about it logically and critically moving forward. So one of the reasons why this change is important is because the triggers and dependencies within the OnCore task list, where all work product is managed and other groups are tickled and triggers and dependencies are satisfied, all of the contracting tasks are being removed from all of those because that group is no longer with the College of Medicine team. And so DSP contracting team accepts all contracting requests, whether they're new, whether they're revisions, whether they're funded, whether they're unfunded, whether it's an MOU, a DUA, whatever type of contract you need. We manage all of those processes via the university's official system, which is the award management system that we call UFirst. So I've got a hyperlink there. If anybody's unfamiliar with that, that can get your feet wet. Claire, I'll share this presentation with you if you want to distribute it to your listservs afterwards. And like I said in the beginning of the discussion, anybody that wants a one-on-one discussion about nuances, please feel free to reach out to me. And so the goal of this and why this change management is important from our perspective is to further standardize the contracting approach across the entire enterprise so that we can create a little bit more predictability about when you need something done, this is where you always go, and complete and honest transparency within the contracting space, because UFirst is very sophisticated. It can log communications, it can log approvals, it can do all these things that kind of get lost at the task list view, where you're just looking to see if something is done with a date stamp. So it will give units a greater glimpse into the details of what's done in the contracting space when everything is routed through UFirst as the frontline approach to making a contracting request. And then obviously utilizing the university's official system to make those requests helps ensure timely routing, negotiation, and execution of all of those things that you may need the contracting team's assistance with. So probably anybody who's either a submitter or an IRB coordinator or anybody that's got a staff assignment tab has probably seen some form of this, which is the standing process for budget approval for new work that comes out of the CRH team. And there's some good information in here about what you should do next, but in a global view, this is your fast pass or your ticket, so to say, to kick off your proposal workflow process so that you can make the contracting request based on the budget that's been leveraged against the coverage analysis review and OnCore through Claire's team to make sure that we've approved that budget institutionally for all those standards that the CRH team is responsible for. So the pivot or the change in the process specifically for today is what happens when you have a modification. And I think the lion's share of this work is what we call budget comes, budget goes. You have a budget that you've agreed to, some things have changed, maybe there's more MRIs, maybe there's more blood draws, maybe there's home health, maybe there's whatever, and you want your sponsor to pay for it. So typically you get a protocol change, budget change, contract change, and there's been a kind of an antiquated task list process that's kind of a handoff. You're going to start getting backs for revised studies, and it's going to give you some better information about what to do with that revision approval next. And so we're going to walk through that process here in a minute, but backs are going to starting to be issued for new approvals as well as revised approvals, and it will give guidance and direction about what to do next should you need contracting. So specifically what's changing, obviously, like we've been discussing, If the contracting team's tasks are removed out of OnCore, we will no longer get manual notice that something's been approved and it's time for contracting. So in April of 2024, we deployed this for the new work. It took a little bit of time to get everybody's processes reframed. I would imagine a similar cadence to this process that we're hoping to roll out sometime in the beginning of October 25, once we have this discussion and then any further discussions that are needed along the way. So I'll go over quickly kind of just a reminder of the new process workflow, and I'm going to go through it really fast. And so if anybody wants to follow up on that, please do. But you submit something to CRH, they build it for you, they approve your budget, they give you the back form. That's your trigger to go to you first to route a proposal. The DSP proposals team reviews that proposals. They leverage the back form to institutionally approve the submission to make the contracting request. And the contracting request on new work is generally made by the pre-award team person that approved your proposal to ensure a very timely transition into the next phase, which is from proposal to agreement. And so for revisions, a nuance is going to be added onto this. What fund code are you dealing in? The first bullet point is what we call 214 projects, which is its own separate fund code, which is kind of what I would consider to be bread and butter work, where we're one of 100 sites enrolling based on sponsors protocol and sponsors global IRB approval, either under FDA, IND, or IDE oversight. And the university is both budgeted and paid on a per patient basis. That's what the 214 fund code is for. And then you go into different flavors of award management under the 201 and the 209. The 201 fund is easily defined as federal funding, whether it's direct federal funding or flow through funding. A 201 fund is only for those activities. And then your 209 fund code is for anything that's grant funded, milestone funded, other budget restrictions, things of that nature that require more meticulous management. And those processes are for changes on those are done via award mods, not contract amendments. So we'll talk about the depth of that in a few minutes. So in an effort to be as clear and honest as possible about how you start to move in this direction to do this, I think fundamental to that conversation is you need to know your OCR number. So the back form has those numbers deposited in them. You can find them in OnCore either by searching the short name, searching the PI, searching the unit. You should have a firm grip on what OCR number you're going to make a change request on before you start going down the lines of, is this 201, 209, 214, where do I go? So having a good understanding that all of this is driven by the OCR number, I think is kind of the baseline. I'll use this opportunity. I didn't ask Claire if this was okay, but this is going to be a plug for the CRH team's sanity as much as ours to maintain the health and wellness of your staff tab on your OCR numbers that are active, because you can see these starts and stops of all these different staff members, things change, and that's fine. But these notices that are going to be coming out about new and modified backs, they're going to go to people that are named on this staff tab. So it may be worth individual units taking an intentional pause to review internally who might be responsible for the UFirst interface. Like, we've got acronyms for everything, just like everybody on campus does. But generally that person is called the PUAC, the primary unit administrative contact. It's usually an RA equivalent that's responsible for either budget, proposal, or DSP interface. So if that person's not part of your clinical trial workflow, you may have to have a local discussion or a local handoff as to if that back form goes to the submitter, which I'm going to use Julie Segura because I love her, and she's not the person that's going to do that next step. Julie will be getting the notice of approval and need to make that handoff with all the appropriate documentation for whoever's going to trigger that contracting request. So shameless plug for the health and wellness of OnCore. Staff tab, super important. I go there all the time to figure out who's on first, who should I work with, etc. This may be a good moment to kind of clean up your backyard, for lack of a better term. So like I already kind of illustrated mildly the differentiations of the fund codes. There's here, I'm not going to reiterate them, but all of this is based on the University of Florida's expenditure policy. So I've hyperlinked that in the bottom. If you're having trouble sleeping one night and you really want to get into the depths of what type of money the university handles, feel free to go read that. You'll probably have a great night's sleep after that. So technically, how does one do this? And I'm going to kind of fly through this really fast because most RAs are familiar with the process, but this is kind of like I said, a very zoomed out global discussion about this. And so, like I said, if you're dealing with the butter work, which is the 214 fund, prospective observational or clinical trial work that requires management and OnCore, meaning that you've got billable services, you're using IDS, blah, 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 all those things that are OnCore criteria. It's tracked by OCR OnCore ID, OCR number / OnCore ID. So you can find any contract that is associated with that OCR number, whether it's a clinical trial agreement, whether it's a CDA, whether it's whatever that's relatable to that. If you change the filter by OnCore ID, as I have highlighted in yellow here, as well as insert your OCR number, it will return for you all contracts that are relatable to that. So like here, this OCR number is for some study called Freedom, and we were able to find it. So once you're able to find it and you click on it, your navigation is on the left-hand side of the screen. And basically what you're looking for, you want to create a modification. And once you click that button that's highlighted in yellow, you can navigate to the baby blue modification tab and you can see the mod that you need to work on. When you're in the body of that mod, once you open it, there's not always 5 things, but these are the 5 most common things that are needed. Obviously, if you need a contract amendment, you need the Word document of the language of the contract that needs to be negotiated. You will need documentation via the revised back process about the approval of the budget, an Excel copy of the budget that's been CRH approved. And I know sometimes those budgets are embedded within the body of the contract, that's fine. But whatever it is that led to CRH giving you an approval of that modified back or that revised back needs to be included with the submission. And then any other supporting documents, like if they want you to entertain a new data exhibit, they want you to entertain some other type of business associates agreement with a third-party home health entity, whatever it is that's coming along with that, please include that. And just like we have staff turnover here at UF, CROs and sponsors have a tremendous amount of staff turnover. So if Jay Epperly at medpace.com left MedPace 2 years ago and we haven't touched this contract in 3 years, nobody will know who to contact on the contracting space unless that information is updated. And I would assume that a majority of time the units have been engaging with those individuals leading up to the contracting request. So getting all of that data integrity updated within the submission is going to be paramount to ensure that smooth timeline of review progressing to finalization. And when you're done uploading all that information and you feel good about your submission, you must then submit it for review. So that's also on the left-hand navigation pane, and it's a simple click. And if you've satisfied all the red asterisk elements that are required to move it forward, it will route to DSP to our bucket for assignment, which is what I take responsibility for distribution to the people that are working on what we call the clinical portfolio now. I see something in the chat. Irina, if it's all right, I'll answer that question at the end in case there's a stack of questions, but that is a good question and I will definitely get to that. So a different flavor of work that can be clinical trial can be things that are either grant funded or federal funded. I'll specifically just call out the NCI cooperative group portfolio for cancer-centric studies. Those are typically federally funded. Those have a completely different process about maintenance, and it falls more in alignment with what I would say the rest of campus does, which is when you have maintenance on something that's an active award, you process those via award modifications, not contract amendments in the agreement module. So I know that's an interesting concept for anybody that doesn't really live in that space. So I don't want to spend too much time. We can deal with that with specific questions, but the 214 fund project view snapshot, I don't really know the right way to say it, so forgive me if this rubs anybody the wrong way, but it's a little bit less sophisticated because the 214 fund is a cash-based modality. It doesn't behave as intricate and as nuanced as classic awards or federal awards or Michael J. Fox grants and things of that nature that have other terms and conditions. that treat the money more like an encumbrance than a cash-based modality. So I don't want to get too far in the weeds with that, but just know that the process is different depending on what color of money you're dealing with that's funding the activity. Typically, the fastest path to discover what award number you're working with would be to route back to your funded proposal. Click on that related items tab that I have highlighted there in yellow, and it will show you everything that's been related to that. So if you were to do that on a 214 fund, you would not see an AWD number, you would see a P number. And in your mental gymnastics, that would drive you in the direction that you're dealing with a 214 or a cash-based account. Versus this one that I have displayed here is a cooperative group clinical trial through the NCI, and they must be managed in the award module in the 201 fund because they're federal. So when you find your award similar to a contract amendment request, you're creating an award modification request. And once you identify that you've initiated that, you drill down under the mod tab to find the mod that you're starting. The status will be draft instead of completed. And then when you open that, similar to what I displayed about what's required for a 214 contract amendment, it'll ask you for demographic information that's changing, plus if it's a financial change, and ask you to upload those supporting documents as well. So I've listed a bunch of different resources here. There's obviously UFirst training available if this is novel for anyone that thinks they're going to assume this duty moving forward. If you need an environment that's kind of safe to kind of poke UFirst and play with it a little bit, we have a testing environment that's a non-production that you could go in there and try it. If you're nervous about maybe doing something wrong in the production environment, there's a whole different area where you can do anything and you won't hurt anything by trying to process one and kind of feeling your way through it. HR has a bunch of professional development toolkits around award management and how to interface with UFirst and contracts and grants. DSP has specific instructional guides around award mods, how to submit an agreement, and then obviously there's a large bolus of UFirst resources available. So I've got all those hyperlinked there. If anybody's interested in those, again, I'll give this to Claire and it can be distributed through the channels. So I know that was kind of shot across the bow, kind of feel for it. I know that's not everybody's responsibility. There's over 100 people here. So there's probably people that this has no effect on me. But it's gonna be a change, and I'm committed to working with the community to kind of help navigate it, because I do understand the longstanding history has been much different. So I'll address Irina's comment. Agreement modifications can be generated by anyone. There is no restriction on that. If you've got the appropriate roles in UFirst to have access and your GWA management is accurate, you should be able to see things that are under your department or your shared service modality, depending on where you're organized, in order to process those requests. But if you run into those restrictions, please feel free to reach out to me and I will definitely help you navigate that.
And I will note the process for us issuing backs is going to be altered. So typically you guys have been receiving a DocuSign PDF attached to an email. What you will be receiving in the future is just an email with the exact same text in there. So it'll need to be saved as a PDF and then uploaded. But this will allow us to reduce some of the time and the administrative burden for creating those backs and issuing them in order to expedite the ASRF process, so there is no additional delay due to the fact of waiting on paperwork from CRH. It'll have exactly the same text in the email, but it will come as the body of the email. So I just wanted to note that. And the other thing I would note is if you are utilizing a different back form for whatever reason, whether it be for an IIT or for a cooperative group study, if there's like a blanket back that you've received in those cases that you've utilized when there is a contracting component, but there is no budget that can either be negotiated or reviewed, you will continue using the same methods that you were using prior. The OnCore staff roles. So right now, the way that the backs are going to be issued is based off whoever submits the amendment in REDCap. So submits the ASRF or a revision in REDCap. However, if the submitter is not matching a role in OnCore, we will use the primary study coordinator. If that doesn't look like it's been updated, we will use the PI. If that doesn't look like it's updated, we'll go to financial coordinator. And we will be able to post any of the materials that have been shown today on our website. We also distribute them, and we're recording this as well. So everybody will have access to this.
Yep, and again, I'll just kind of reiterate that if any unit has a specific concern or they want to kind of rally the troops, so to say, and have that conversation amongst the clinical team and their RAs to discuss that overlap with me present, I'm more than happy to schedule some time for that.
Any other questions for Jason while we have him here? Okay. Any other questions on the back and how it gets issued, what you need to do with it afterwards, because this will be a change in process going forward. So the main concern for the OnCore staff tab is making sure that everything is accurate and up to date. So some are missing financial coordinators, some have staff that are gone, still being recorded as the primary study coordinator. There's some situations where PIs have changed, but those changes are not reflected on the staff tab, or they have not been submitted to CRH. As a reminder, if you have a PI change, please submit that to CRH so that we can get everything updated. It also includes a push through to Epic if the study is in Epic. So we need those information in there.
Claire, is there a specific way to request updates to the staff tab, or can anybody who's currently assigned to the OCR number update their staff tab without like asking for permission or approval?
Anybody can update the staff tab. However, that push does not always go through to Epic. So if you guys are aware of staff changes, please just update the staff tab in OnCore. If you do not have that permissions or you have questions about it, please just contact us. You can contact that com-crh@ufl.edu email that issues a ticket for the whole team to see, to be able to help you resolve. You can also always submit a front door request to let us know as well, but it is a very simple process and we have that to go through as well.
Well, I appreciate everybody's time. Like I said, I'm familiar for a lot of people, but my email address is in the slides. I'm not hard to find. If you got any questions about the change and how you first operates or it's behaving weirdly for you, please reach out to me, because the quicker we can kind of either identify bugs or quirks and things that aren't going to work, the quicker we can get the community the benefit of that improvement. So if you see something or you're struggling with something, don't try to go at it alone. I'm available and I'm willing to help.
Well, thank you so much for your time. This has been helpful, I'm sure, for everybody, especially for me, and I appreciate the resources that you've created with the PowerPoint. So
Yep, and I will follow up and send that to you offline, Claire. I've got another commitment I got to go to, but thanks everybody. I appreciate y'all's time.
thank you.
Yep.
Next up, we're going to ask Melissa Sykes to join us on stage and finish the presentation I unfortunately had to cut off last month, just highlighting some responsibilities in the management of studies in Epic. And one of the things that I know that she discussed last month, and she may touch on this month, but I want to highlight is, please, if you have a patient in Epic that has a billing grid built in OnCore, so if it has a calendar, you need to generate the timeline for the patient in Epic. Our current utilization for that number is 33%, meaning only 1/3 of the patients in Epic have that timeline generated. Without that timeline being generated, none of the functionality from the budget build or the Medicare coverage analysis in OnCore is being utilized in Epic, meaning none of the charges are being auto-bucketed based off the Medicare coverage analysis. There's additional logic that's being used with linking and stuff like that, but the whole crafting of that element is not being utilized. And there's also other abilities of generating a timeline that is helpful. And it's a pretty low effort ask to be able to attach that timeline to the patient. And I know Melissa has provided tools on it. If you're uncertain on how to do it, please reach out to us and we can help. But it's going to be a big push. You're going to start receiving emails if we run a report and it looks like there should be a patient with a timeline that doesn't have one in Epic, asking you please to generate those, because I would really like to see those numbers much higher. Currently, Jacksonville is in the 70% range. I would love to be able to match them, especially since we are bringing the Epic instances together. So with that, I'll hand it over to Melissa. Thank you so much again.
Let's unmute myself first and foremost. And then I'm going to share this slide presentation. I always seem to have trouble with this, so bear with me just one second, and I will get this shared. Screen. Do you see my PowerPoint? It says research touchpoints in Epic.
Yes, I see it.
Okay, wonderful. Okay, so we're just going to go through and talk about some of these. We think we are. It's not clicking. There we go. All right, some of the topics we're going to talk about are just things that as you're doing things in OnCore, there's other items that have to be touched in Epic, and some of the study team's responsibilities, maybe some things that we've seen that are missed along the way. So we just wanted to take this opportunity to kind of talk about these. So one of those is maintaining the research study record in Epic. Yes, it gets created in OnCore and then it passes through it interfaces to Epic. We're going to talk about uploading informed consents. We're going to talk about research encounter linking and research order linking. Study administrative record. It's called a million things. It's the protocol. It's the RSH record, but basically it's your study record that lives in Epic. So a study record has to live in Epic before you can associate your patient enrollment records to the study, before you can link encounters to the study, and before you can link on orders. It's pretty self-explanatory. If your record isn't in Epic, you have nothing to link it to. It's also necessary for billing to route those research related charges to that guarantor account. So charges drop, route it to your study. Study records are, of course, I've already mentioned that, managed in OnCore and interfaced over into Epic. The study team, you guys are responsible, and I think Jason and Claire both touched on, please maintain your staff tab in OnCore. It's very important to do so in Epic as well, and to make sure those two match. So your basic responsibility in the Epic world is to make sure your users and providers are appropriate, like it's shown on this screenshot down on the left. So make sure your PI is still your PI. Make sure all of your coordinators that are working on your study are listed. And you also are responsible for maintaining the study statement recipient email addresses. If you are no longer performing that duty and getting those invoices and paying those bills back to UF Health, we need to make sure that gets updated. Otherwise, you won't receive your bill. Here are some key indicators for users and providers, some things that might be happening. If you see these, you might go, aha, I need to update my staff in OnCore and Epic. So if your staff that's responsible for charge review has 0 results on your patients needing billing review report, you're probably not listed on the record. 0 charges is probably really rare. So if you're like, I run the report all the time and nothing shows up, probably need to be added to as staff in OnCore and push that over to Epic. If you can't access your study, your coworker can access it, but you can't. You're probably not listed on the study record. You can't see any participant enrollments in Epic. You're probably not on the record. You see inactive indicators when you open your study, and over here on the right, this graphic displays that. It'll highlight in red. So, or I guess that's a red block and in yellow. So it kind of tells you, oh, Kathy Lee is no longer here, and neither is Dr. Cavallari. And then you might receive an email indicating that you have inactive users and providers in Epic. We have an email that goes out to you, study team members that says, hey, for this study, you have a number of inactive studies on your record. Now, updating users, how do you do it? If your study is managed in OnCore, you go to that staff tab that they were talking about in OnCore and you update them. You also need to, and Claire, I don't know if this is the correct email address any longer, or if it's the other one, the other comm one you'd like them to use.
It'll still work. It directs it the same way, so this is still functional.
Okay. And just let them know, hey, I updated my staff. I made some changes. I need my OnCore record to be pushed into Epic. Because it's not an automated thing. So I've had a couple study team members say, Melissa, I swear I did that work. I'm like, oh, it just needs to be pushed over to Epic. It's kind of rare. I know there are some legacy studies that weren't using OnCore. So if you're still managing your study directly in Epic, you will update that directly on the users tab of the RSH record in Epic. You do have that ability and that access. If you don't, that you're probably not on the study record. So that goes back to making sure you get added to that study record. Wanted to mention the staff roles in OnCore that actually interface to Epic, because not all of them do. So if you're a principal investigator, a primary study coordinator, a secondary study coordinator, a data manager, or an Epic charge reviewer, those are the staff roles in OnCore that will map over to Epic. If you're listed as a research assistant, you will not cross over into Epic. So you need to be one of these 5 roles. User and provider requirements to be listed in Epic. You must have an Epic account. Your user or your UFID must be mapped. It needs to be listed in OnCore, and that is the key indicator that will interface and map you over to Epic. And then the Epic principal investigators, if you're going to be a PI, you must have an active provider account. Some PIs do not have a user account. I'm logging in into Epic. I'm logging in with Scrogum and with my password. But a PI has to have a provider account. And if he or she doesn't, then you can work with OnCore staff. They'll help you out and get that accomplished. Okay, the other touch point I wanted to talk about was research statements in Epic. It is a single statement. It includes both professional charges and technical charges. The study statements in Gainesville are generated on the 15th of every month. In Jacksonville, they're generated on the 5th. With our Epic modernization project, we're going to align that. So sometime in the near future, we'll be on the 15th of every month instead of 2 separate days. Study statements are automatically emailed to those addresses provided at study startup. And again, if that changes, if that person who is receiving your study statement changes, make sure you let us know and we'll get that updated for you. And it looks a little like this. Let me back up. One other thing to mention about statements. If you think you're the person that receives it and you do not, please put in a service request and let us know and we'll dig in. It's an automated batch job. Something could have happened to the batch job. Maybe you're not on the study record, things like that. So we'll take a look and make sure that everything's appropriate there. Some indicators, and I think I jumped the gun there. So if you haven't received an email with an attached study statement, sometimes it happens the day after the 15th. So on the 15th, the statement generates, and then there's a manual touch point that someone does to make sure that batch job that automation sends out. So if you don't receive it by like the 16th, submit a service request and let us know. But the emails come from, in Gainesville, Shan's research billing team, and in Jacksonville, the Jack's research billing team or physician billing. That will probably align into one in the future. But for now, we have Gainesville and Jacksonville separated out. So you'll be looking for an email from those folks. Now, how do I update my study statement person? Just open a service request. I added all the steps just to be thorough, but there's this template that makes things really easy for you. So you can select, when you go to open the service request, you can select Epic, all other services, the research category, and then within the service, research study statement, invoice recipient updates. Just list your study name and list who to remove if you're changing or who to add. There is a character limit for this field. So it's like, I think 88 characters. If you want 4 different people to get it, likely we're not going to be able to fit that in the field. So you would want to create a email listserv so we can put that in, and then you would have an email group and anybody on that group would receive the statements. I see lots of questions. I think, is there questions?
I don't see any in chat. I know Katie and Barb put some resources in there for people, but I don't think questions yet.
So far. Okay, great. All right, moving on then. Uploading informed consents in Epic. It is a requirement by compliance. A copy of the participant's informed consent must be uploaded or scanned. Once that informed consent is scanned in Epic, it'll appear in the media tab in the participants chart. So if you go to chart review, the media tab, those informed consents will appear there. There are 3 ways. There's probably more ways. There's a million ways in Epic to do everything. So the 3 ways we have called out on the tip sheet is you can scan using a non-base scanner. Of course, it requires appropriate Epic access and permissions, but most UFP clinics, like if you're doing space in an outpatient clinic, they're likely to have a scanner, and you can just go, hey, I want to scan this, and get it scanned in there. You can also make a copy and fax the consent to the HIM department, and they'll scan it for you. But the easiest way is to upload your own consent. Do the work. You have it. You do have to have a Shands personal drive or a UF Health OneDrive. If you do not, the technical team will set that up for you. Just place a service request and get one. Then you can just save it off as a PDF and then be able to upload right into Epic on your own. We don't have enough time to go through step by step, but I did put in the instructions here, and this is the tip sheet. If you have problems accessing this link, and Claire will have this PowerPoint to send out, let me know and I can send you a PDF version, a saved off PDF version. I know there's some firewall issues on occasion. Now we're going to talk about encounter linking. It's super important when you're having a research encounter or an appointment or anything done that if it's for research purposes, you should be linking those encounters. And this graphic kind of tells you why. It helps other clinicians realize, hey, this person has a research related appointment. It does control the release of research related information. So if you have a double-blinded study and you don't want that information to be released, that encounter has to be linked to the study. And then those release restrictions will come into play. So it's pretty important to link your encounter. It allows study teams to be notified of changes. Like if your study participant changes their appointment from today to 3 weeks from now, you'll get a notification as long as that research linkage is there. And then, of course, reporting. It's very important for reporting and compliance review and things of that nature. So study teams must ensure that all study-related encounters are linked to their study. To link an encounter, your patient has to be actively enrolled in the study, and the encounter date must fall between the start date of the study and the end date if they're already in had populated an end date. Encounters should be linked before the visit happens to ensure that the patient and the study are billed appropriately. When OnCore billing calendars are in use, Epic timelines should be created and maintained. And I know Claire touched on it. I'm just going to beat the proverbial horse. That is an absolute must when you're using calendars. You have to have a timeline and you have to link your encounter for all of that work to automate. And I promise you, it's on the back end, it makes your job a whole lot easier. So if you link up front, make sure you have your timeline, your billing review is going to be so much easier. And you can proactively monitor your visits for your patients who are coming in and check that linkage using Epic reporting tools. And the tools are the appointment search for research study patients or participants. This report is going to look for all outpatient appointments. It's currently set up to look from today to 2 weeks out. So if you run that on a daily basis or even every other day, you can find those appointments that your participants are coming in for, and you can proactively link them from that. The inpatient admissions report, this is a work in progress. It works for some individuals. It is a little bit problematic right now. And between myself and Aaron and Stacy, we are working to move to a better method of searching for those admissions. So bear with this, work in progress for sure on the admissions. You also can use the registration functionality in Epic to find that encounter, go to the registration and link that there. Those are also step-by-step instructions on a tip sheet. I think I do have that listed at the end. Oh, look, boof, I do. So outpatient encounter linking, here's the tip sheet, step-by-step on how to do it. Inpatient encounter linking, step-by-step on how to link it. Number one takeaway is it's very important and you really need to link them and add your timelines. Order linking, same thing as encounter linking, important thing to do. It controls that release of information. When you link your order, it automatically, that's a little odd. When you link your order, that charge that drops from that order will automatically bucket to your study account. So it helps drive efficiencies for your bill review. You can look into the chart. You can easily identify those research-related orders and results. It also drives results to your providers and your study coordinators in basket, so you can see those results. And I guess, and facility reporting as well. All research-related orders should be entered into Epic and should be associated to the study. So if it's for research, link it. You can do it several ways, depending on where the service is going to be and the location. So the PI could enter and sign the order. I know that's probably not benchmark. It's probably you as a study coordinator entering the order, or an attending physician can enter the order for study team guidance. I believe that works a lot in bone marrow transplant or the infusion center. That happens on occasion, like your PA is going to enter the order and they're entering it for you. Just make sure they're linking it to the study. Study coordinators can also enter order, but save the work for the PI to sign. We as study coordinators do not have licensure to sign orders and make them active. You can also do outpatient ordering via orders only at counter, or inpatient ordering, you'll be using the manage orders activity. It looks a little like this when you place an order. What you're looking for to do that linkage is the research association, the one that's circled here. If it's grayed out, your patient is probably not actively associated to the study. So that you'll need to backtrack, associate your patient to the study, and then link your order. So it's simply choosing this option, and then all of the studies will appear and you'll link it to the appropriate study. Here are the step-by-step instructions for that. With this most recent upgrade, which was September 10th, I believe, there is an option, which we have a tip sheet on that as well. If you forget to link your orders, you can go back and do so. Just remember, if the charge from the order or the result has already dropped, linking that order will not go back retroactively to do anything. But it will give that compliance aspect of, oh, yep, the link is there. It will give that view for, hey, any clinician can go in and see this was a research-related order. And then if we're in time, we can stop those release restrictions as well. And just on the end, here is the main site to find our research tip sheets. I know this link is also on the CRH website as well. And if you have questions or concerns or something in the tip sheets aren't working, feel free to reach out to us. We'll be happy to help in any way that we can. Any questions?
It looks like there's one question. PI correctly attaches the order to research, yet sometimes it shows up in Epic charge review not linked to the research, and they have to change it back to research. Are you aware of any process in which why this might occur? If it's associated with research, when it shows up in charge review, it should
fall to this. It should fall to the study related bucket. Hope you know what I mean when I say bucket. When you're doing your research bill review, you have study related, bill to patient insurance, study related, and then you have not study related. So are you saying that an order was linked and then when it got to bill review, it was in the non-study bucket? Is that the question? Yes. If you have that example, John, could you place a service request and let us look at it? I would have to go dig in behind the scenes and see, did someone touch it after the fact? Did somebody charge correct it and move it? Did a charge route or piece of logic push that around? So if you have that example and don't mind putting it in an SR, we'll definitely take a look for you. Nothing, the only thing off the top of my head that could possibly do it, the order could link. But if you also have a calendar with a patient timeline and the calendar says something different, that could possibly direct that charge elsewhere. So I'd have to look at that piece as well.
But it would still stay in the study-related bucket, correct? It just may change the designation.
Yeah, it just depends on how the calendar was built.
Okay, thank you. Any other questions for Melissa? Okay. Well, thank you very much. Again, these slides will be made available, as will be the recording and all of the resources that anybody shares today. So if there are any questions come up, we are happy to triage and get the proper party to address it. I do want to highlight a few changes with this month's Hub Talks and things you'll see in the future. So you probably saw an invite come through as an Outlook event on your calendar yesterday for Hub Talks. In the future, those will come out earlier, and that's how you'll be invited to Hub Talks, kind of a simpler thing, be able to keep it held on your calendar and kind of be able to be aware. One of the things we are doing is attaching documents to the invites. So we've created, or Nisi Black on our team created the Hub Talk Pulse, which is essentially just like a newsletter, updates that didn't necessarily make the presentation, whether time constraints or just volume. There are a number of updates on the one that I attached to this month's meeting. So I would recommend checking it out and just seeing it. It talks a little bit about the back process. But the other thing that it talks about, and since we have just a few minutes, I am going to highlight it, is the new training curriculum to be able to get OnCore access. Now, in the past, there's been, I believe it's OCR 810. Katie, correct me if I'm wrong. But it was a almost 2 hour training you took once and you got OnCore access, and it was generic across whatever type of account you needed. What we wanted to do is better align access with training and making sure that everybody kind of had standard access. So if you're a study coordinator, you have study coordinator access, and everybody who is a study coordinator has the same access. If you're a PI and they actually need an account, so it's a PI who's going to go into OnCore and do something, that they have the proper training and they know how to utilize the system, and there's PI specific training. There is also financial coordinator training. So somebody that's not necessarily going to see patients, may not be entering patient visits, but is going to do the financial post-award management of the study. There's financial coordinator training. Now, we're not asking anybody who already has OnCore access to go back and complete these. They are available if you want a refresher. Each of the courses individually is available. The curriculum as a whole is available if there are things that you want to learn and touch up on. But moving forward, if you want to request an OnCore account for somebody new, this training will need to be completed. And I included the link in the PDF I attached. It's also available on our website. You can also just go to our learning management software for UFL. I think it's UFL Train. I'm not sure exactly the platform, but it's where you do all of your compliance training, the HIPAA training. It's all hosted in there. And if you search OnCore, these curriculums will come up and they're available. We tried to keep them as relevant and simple as possible. So we tried to really understand what permissions we were giving and what we wanted people to have. The PI one, I will say that if you need to add a new PI and they do not need to access OnCore, we can request them to be added as a contact. They will not be able to log in the system. They will not be able to look at anything, but it will be able to reflect in the system that they are the PI without them having to complete the PI training. So I just wanted to make that because I know that's a concern. If you do have a PI who is interested, they want to get in the system, they want to look at it, they do have to complete the PI OnCore training. Any questions regarding this or this change? We will also have a new OnCore account request form. It will be issued beginning of next week. It'll be simple. We'll ask you which type of these accesses do you need, like who are you requesting for. It will have to be signed off by the manager of that person, or whoever's making the request needs to have that supervisor sign off. But I just wanted to make everybody aware of this. Again, these classes are available. They come directly from Edbara, so these aren't the UF specific classes. It's just overall general how to use the system. Okay, I just wanted to highlight that for everybody. I'll open up now for any Q&A for the last about 5 minutes. Is there anything that anybody has any questions about, any comments, concerns, anything that they want to bring up that we can address while we have everybody here. Okay. Well, if you do, you know how to reach us. And like I said, we're going to work on getting this updated and sent out. If there's anything on that Hub Pulse that you look at and you have questions about, please let me know. Like I said, also please make a point to go back and generate timelines for patients that don't have them. If you have patients in Epic, and if you are enrolling new patients, please make sure you generate that timeline. I really want to get that up, and it will allow for more functionality to be able to be crossing through from OnCore to Epic. It'll reduce duplication. It'll really be beneficial for everybody. With that, everybody have an amazing Thursday, and we'll see you next month.